Hello and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Sharif Mursalin. Today's podcast features Dr. Pier Luigi Zinzani from the University of Bologna and Dr. Max Topp from the University of Wurzburg. They'll be sharing their insights on the therapeutic advances and practice-changing data emerging from the 2025 EHA and ICML Congresses. For more information on our presenters, along with a link to the full educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
We got the chance to discuss 6 very exciting abstracts that were presented at EHA and ICML. And we do believe that these are either practice-changing or will give us new directions in the way how we be treating patients in the future with lymphoma and also ALL.
So the first abstract was presented at the last EHCML meeting in Lugano a few weeks ago by Dr. Matazar from Memorial Sloan Kettering in New York. And he presented the final data of a phase 3 randomized trial called POLARGO in relapsed refractory diffuse B-cell lymphoma ineligible for transplant. It's a very simple phase 3 randomized trial comparing the study arm is R-GemOx plus Polatuzumab for 8 cycles versus the control arm, the GemOx, R-GemOx plus GemOx plus Rituximab for 8 cycles. The study included more than 120 patients for each arm with a ratio 1:1. The primary endpoint of the study was the overall survival. And this primary endpoint was met because the median overall survival was 19.5 months for the study arm, POLA plus R-GemOx, versus more than 1 year, 12 months for the control arm R-GemOx. And the median progression-free survival at the same time was statistically significant in advance of the study arm, POLA plus R-GemOx, because it was 7.4 months versus only 2.7 months for the control arm R-GemOx. In terms of secondary endpoint, the overall response rate was close to 50% for POLA plus R-GemOx versus only 25% for R-GemOx. And the CR rate was 40% for POLA R-GemOx versus only 19% for R-GemOx single agent. In terms of toxicity, the hematological toxicity was quite similar. Of course, in the POLA R-GemOx studies, there was some peripheral neurological toxicity. This could be considered a very interesting study concerning the really important role concerning the addition of Polatuzumab Vedotin with the conventional chemoimmunotherapy R-GemOx in this setting of relapsed refractory patients with diffuse B-cell lymphoma ineligible for transplant. This advantage is possible to observe not only for the primary endpoint in terms of median overall survival, but also in terms of median progression-free survival, and at the same time better overall response rate and also CR rate that is close to 40%, as I said before, without any kind of really difference in terms of toxicity, only of course, the peculiar toxicity related to POLA. I mean the neurological toxicity, but as you know, is reversible in the most part of the patient.
Well, I think this is a very interesting abstract, particularly because it shows an OS difference for the experimental arm. So now we have the abundancy that we have now 3 phase 3 trials showing OS difference with the experimental arm. I mean, we got the STARGLOW, and we got also CAR T cells in the SUMO-7 trial.
That is quite unbelievable because
right.
It's very important, and everybody knows that the FDA, EMA, the drug agency, prefer to have this kind of difference when you have a phase 3 randomized trial. But at the same time, I think these data are good, but in the new era of chemo-free regimen, it could be difficult to accept very well this kind of final analysis of the POLARGO study. But at the same time, inside the therapeutic algorithm of relapsed refractory patient with diffuse B-cell lymphoma, I think there is room also for these new modalities of treatment in a particular subset of patients, elderly patient ineligible for transplant, where the potential competitors could be also, of course, are ineligible for CAR-T, and the potential competitor could be POLA-BR or at the same time or TAFA plus LENA. And it depends patient by patient. We have to evaluate according to the result of these three different trials and according also the different study population of these three different trials.
I agree with that it is really very nice to see that we have these options. And as you sort of said completely, that we have the younger patients with early relapses. I mean, obviously those will be CAR eligible, but for the patients who are elderly or don't have access to CAR T cells, these are potentially very attractive options. So it's very exciting in the field.
Absolutely. It's full of options.
Well, I would like then maybe to take over and speak about an update that Martin Dreiling presented. I thought this was a very, very important piece of information. I mean, the background is he spoke about mantle cell lymphoma patients, particularly the elderly patients, and the ECHO trial established a new standard of care, both in the United States and also in Europe, by actually now showing superiority for Bendamustine in combination with Rituximab and Acalabrutinib. And this is really very nice to see, because we have for the younger patients, the triangle trial, which showed also a real benefit in these patients. And we nowadays don't do any more high-dose chemotherapy based on the trial that Martin Dreiling presented a couple of years ago. But now back to this trial, and why do I feel this is a very important trial? It is first quite a big trial with mantle cell lymphoma, so the authors have to be congratulated, with 600 patients, age 65 and above, and stratification between the regions and MIPI. And we have seen this data being published in the JCL by Michael Wang. And Martin spoke at ICML about the patient population that we really do fear in mantle cell lymphoma, the high-risk disease population, defined as follows: high-risk MIPI, Ki67 by 30% plus, P53 mutation, and of course the blastoid subtype. In this trial, they were well balanced between the experimental arm being the ACLA plus BR and the placebo arm for both the age, tumor bulkiness, LDH, also between the whole population, but also the high-risk population. And as you would imagine, the high-risk population, there was a trend of higher LDH, tumor bulk, and a higher MIPI, but that was to be expected. It is very important to understand that in all the risk factors that Martin presented, if it is the MIPI, if it is Ki67, also 30% or 50%, depending if it is the United States, where you quite often have 50% of Ki67 being important, or 30%, or even with patients with blastoid mantle cell lymphoma. There was, for all three of these subgroups, a significant benefit in PFS, in the primary endpoint of this clinical trial, adding ACLA to the mix in the situation. So I think this is really very important, and really very important that we know that even these very hard to treat patients, that adding a BTK inhibitor can make a big difference. The toxicity has been reported by Michael Wang in that situation. The only caveat that I do see is that the P53 was not included, and now on a post hoc analysis, Martin has tried to pull the patient data, but obviously they're just few patients, and so it's very difficult to conclude in that situation. But we have to understand that quite often P53 is associated with high MIPs, with high Ki67, and of course with the blastoid phenotype. So I would presumably say, that this is also true for P53 patients in this situation. So with that data set, I think we have another piece of our cornerstone, how to improve further in mantle cell lymphoma patients.
I think Max was another important piece of really important issue concerning this new trial, but at the end of the day, it will be a new indication in the setting of untreated mantle cell lymphoma. It's after the triangles, there is also the echo, and we have the complete new front line for mantle cell lymphoma. And with including, in particular in this case, of a second generation BTK inhibitor, Acalabrutinib. And it was quite interesting also to observe that also in this case, there is a trend in advantage of Acala arm in terms of overall survival. When you skip the COVID, the patient who died for COVID, this is another important point when you come back to the prior discussion concerning that at the end of the day, in the last few years, there are several data concerning the positive role of overall survival when you try the patient with new generation of treatment. I think this is another important point. I have a question for you, which is the real role of, for example, MRD negativization in the setting of this patient when you put this new therapeutic option in the real life? Because as you know, now there are several trials related to the MRD evaluation in terms of to continue the treatment, to stop the treatment, to modify the dose also. Could be difficult to apply these in the real life.
I agree. That is a completely different level. This could be a completely new session that we can speak about the MRD. And we saw a glimpse at Lugano that MRD is going to be what we'll be working on the next 5 years, and how to stratify therapy, because we're already doing so well. And there are subsets. I agree with you, Pier Luigi, where we could perhaps can stop therapy in because still nevertheless, ACLA, all these drugs still have side effects. Like RIA and easy bruising. If someone is MRD negative, do we actually stop therapy in these patients? Or if we have someone who's MRD positive, do we escalate in the situation? Yeah. So we've got lysocell there in the mix, like a CAR T-cell therapy, in some of the younger patients. But is that going to be a trigger point for that? This is kind of, a discussion where we go in the future, but I completely agree with that. And then on the other hand, there's also a subset of patients which actually get away with not using any chemo at all, Rituximab plus a BTK inhibitor. So there's a patient that is completely chemo-free with mantle cell lymphoma. And this is, a very exciting prospect, but also pinpoints to that we have to be very clear on the diagnostics in mantle cell lymphoma.
Yeah, it's a real Copernican revolution in the setting of mantle cell lymphoma, not only for frontline in young patient, in elderly patient, but also in second line, third line, with the non-covalent BTK inhibitor, with a combination of venetoclax plus placebo, according to the sympathic bias. Also, glofitamab, the predicate of glofitamab, in the setting of relapsed refractory patient. The Cadence 101 study was presented at the last Lugano meeting by Dr. Scarfo from Oxaliplatin Hospital in Milan, in Italy, and was involved in this trial. It's a phase 1 study. And with a new drug. It's a very new, interesting drug called BTK Degrader. There are several different BTK degraders so far. This is phase 1 in relapsed refractory patient with CLL or small lymphocytic lymphoma. Of course, the most part of the patients that we enrolled were CLL patients received at least 2 prior lines of systemic treatment, including at least one of them with a BTK covalent, ibrutinib or Acalabrutinib or zanubrutinib. The primary endpoint was the safety and the MTD, because it's a phase 1 study with some preliminary data in terms of efficacy. We included 66 patients, and it's particular because it's a really high-risk study population, because in this study population, we included 65% of patients with deletion 17 and or p53 mutation, and at least 50% of patients had complex karyotype. And the median number of prior systemic treatment was 4. So really high risk, heavily pretreated patients. In terms of toxicity, this BTK degrader, there is fatigue in at least 1/3 of the patient, but in 90% of the patients is grade 1 or 2. Bruising in at least 30% of the patient, but all grades 1 and 2. In terms of peculiar toxicity in the setting of BTK covalent, of course, also in BTK degrader, atrial fibrillation was observed only in 2 patients out of 66, and both of them are at grade 1. And in terms of major hemorrhage, one observed only in 2 patients. So at the end of the day, the safety profile is very good. And at the same time, there is a rapid improvement of cytopenia. And this is another important point. At the end of the day, of this phase 1 study, there were 6 different subsets in terms of different doses, and the MTD was 200 milligrams for the phase 2 study. The doses ranged between 50 milligrams until 500 milligrams. And another important point is the median time to response was close to 3 months. Also, this is another important point for our patient. But if we move to efficacy, I mean, this is a second endpoint in the setting of a phase 1 study, but the overall response rate was more than 80%. The CR rate was only roughly 5%. But I think it's important. We are talking about CLL patients. The overall response rate in heavily pretreated patient, high-risk patient, is close to 80%. But in particular, when you stratify some subset of patients, I mean double exposure patients, I mean a patient who received BTK inhibitor covalent and also BCL2 inhibitor, 95% overall response rate. For triple exposures, I mean BTK inhibitor covalent, non-covalent, and BCL2 inhibitor, 75% overall response rate. Patient with deletion 17 and or p53 mutation, 82% overall response rate, and complex karyotype was 73% overall response rate. And last but not the least, in patient with BTK mutation was 75% of overall response rate. The progression-free survival at 1 year was close to 80%, and at least 65% of the patients are still on treatment with a median follow-up of roughly 15 months. I think this real phase 1 data, but could be a very important new strategic drug for the future of CLL. There are also preliminary interesting data not only in CLL but also in palindrome disease, at the same time also in marginal zone lymphoma, mantle cell lymphoma, and diffuse B-cell lymphoma.
Yeah, I agree. This was really also a highlight, and particularly also having a new drug class being now really hitting really the forefront. And particularly, I was very surprised by the efficacy of the triple exposed patients. That is really breathtaking with that high efficacy rate and the duration of response. On the other hand, the tox profile, I mean, it just speaks for itself that I think that this drug will move up the ladder quite quickly. Won't be stuck in 3rd line or 4th line. It is going to be something that to look out for.
And also
the
next
second
step
line
could be also the combinations.
Exactly. exactly. When you add Vento in the mix or something like that, I mean, that would be very exciting, or with immunotherapy or so. I mean, it is also something, I mean, we have spoken about last year's using CAR T cells in CLL, and it has been a disappointment, to my opinion. I mean, 25-30% is not good enough for something like that. But this obviously is a drug that can be applied to all the CLL patients, particularly also the elderly patient population, I mean, which aren't eligible for CAR T cell therapy. And so this is really very exciting.
And also, I think the future of CAR T in the setting of CLL patient could be to move as soon as possible from the right to the left. I mean, in the second line, because we discuss it every time concerning the sequential treatment for our patient to stabilize, to control the disease for 15 years, 20 years, and more. But the real problem is that there are at least 20-25% of the patient with CLL with an age between 40 to 50. And what to do? Potentially, we have to try to, after the frontline treatment, to do allo stem cell transplantation for each patient to try to cure this patient. And at the same time, another opportunity to try to cure could be CAR T cell, if there is this kind of possibility to use, why not in second line, where we can increase also the duration of the response and potentially we can cure a small subset of patients. I think this could be another important issue for the future about the therapeutic algorithm for CLL patients, to try to discuss also what to do in really young patients, because it could be difficult to stabilize, to control the disease for 40 years.
I agree with that. And I think also, I mean, you didn't speak about it, but MRD testing would be also a very important tool here because it's so established. I mean, we have seen that now with other trials at frontline where there is the approach of using MRD to tailor the therapy. So this is sort of another way, another angle of technology that will help us here to actually who to take to which therapy. I mean, in a younger patient, if they have a very swift response and become MRD negative, then, well, you maybe can withhold transplant. But if you have a patient who is a slow responder, particularly in the second line, and doesn't clear MRD within a certain time frame, that's a candidate that we have to expose, something like that.
Again, MRD is everywhere.
Is everything, yes. I will like to talk about the use of Tafasitamab in the situation of the first or second salvage of follicular lymphoma. I mean, the data was reported the first at the late-breaking abstract and at ASH last year. The full publication is not yet out there, so we have to watch the abstract. But it has already been now approved in the United States, and I think it has a positive opinion also in Europe. So we will see this drug very soon moving into the space in our guidelines. So this trial also is a big trial, international trial, many countries. The InMIND phase 3 double-blind placebo control. So this is a very important. There were more than 400 patients being selected, one-to-one randomization. Primary endpoint was the PFS, and also talk about key secondary endpoints, PET negativity and secondary PFS by investigator and OS. There was some update on this here, looking at particular questions. For example, what about the previous therapies these patients have? Because as you we have, when we treat a lymphoma patient, there are R-Bendamustine, there are R-CHOP. In some areas, regions, we use R-square, or even just Rituximab monotherapy, which is not a bad idea actually in lymphoma, in follicular lymphoma. So, and they also spoke about the PFS by baseline risk factors, so and prior therapies. They also addressed the question in these updates on histology transformation, and of course also, which is very important, considering what happens to CD19. Talking about CAR T cell therapy as the next line of therapy in a patient who is relapsing, particularly when we know the good lysocell data that we have with CAR T cell therapy. So this is very important questions.
Another important presentation, is true because in the setting of follicular lymphoma, now we are talking about from the second line, but also in this case, there is a revolution because this is a chemo-free regimen in mind. And there are also, as you know, and everybody knows, the fantastic data concerning EPCO plus as well, or also the MOSU plus LEN. And the future in the indolent disease such as follicular lymphoma could be really free for every kind of conventional chemotherapy. We are waiting for the second attack to the front line concerning, there are 4 different phase 3 randomized trials, chemo-free versus the conventional chemotherapy. Probably in the next 2-3 years, the most part of them will be positive, and finally we can conclude that we can try to cure the most part of patients with follicular lymphoma without any cytotoxic therapy. What do you think about this kind of really close future for our patient with follicular lymphoma?
I'm completely excited about this situation. I mean, it's a dream to see chemotherapy, being abolished. And I always like this a lot because we most likely will have a bispec targeting CD20 in the front lines, hopefully without chemotherapy. I mean, as you said, a couple of trials exploring chemo-free, true chemo-free regimen. And then if that patient relapses, well, we can say, gee, we can have here another approach. And in terms of we're adding CD19 to the mix as a targeted agent or something like that. So we got CD20, CD19 sequentially being targeted in that situation. And we can then proudly speak to our patients, say, gee, we got here something which is chemo-free. And this is a dream, Pier Luigi. I mean, that's basically where we grew up with chemotherapy. Then we added Rituximab. Well, we thought this was magic, but now this is the time for the magic bullet.
Yeah. But sometimes you have to pay attention because when you start with the patient, I think it's important to have a vision concerning the sequential treatment of this patient, because sometimes you can close some doors if you use a kind of monoclonal antibody before instead of another one. You have to avoid the role of Bendamustine in terms of potential utility of CAR T-cell. But another important point during the presentation of Loricel at the last ASH meeting, but also training here in Lugano and EHA concerning InMIND, is that one of the secondary endpoint, the complete metabolic response, was not so different when you compare InMIND versus R-square. R-square is quite active because it was 50% of CR, complete metabolic response, for InMIND versus InMIND for the study arm, Tafa plus R-square versus R-square was 40%. Now we move to peripheral T-cell lymphoma. So T-cell lymphoma, represent more than 12% of all non-Hodgkin lymphoma. The result in terms of, in particular, relapsed refractory patients are quite poor. But at the last Lugano meeting, Dr. Sean presented the final data of the second part of the phase 1 study using a new drug with is SHR2554, is a AZ2 inhibitor. Is a new pathway for the setting of peripheral T-cell lymphoma patients. And of course, this was a phase 1 study. As the first part, they reached the MTD was 350 milligrams. Is an oral formulation until progression, and in the setting of relapsed refractory peripheral T-cell lymphoma, including NOS, algimmunoblastic, and anaplastic ALK positive, and also ALK negative. And in terms of age, they included patients between 18 and 70 years, and at least the patient had to receive 2 prior lines of systemic treatment. including conventional chemotherapy and one of the new agents, such as, say, Gemcitabine, that is quite common in China. And the primary endpoint of this phase 1 study was overall response rate, according to the independent central review on the basis of the Lugano criteria 2014. They included 67 patients, 55% were angiomyoblastic, more than 20% NOS, peripheral T-cell lymphomas, and at least 15% anaplastic, ALK positive, and ALK negative. All these patients received at least two prior rounds of treatment, and the CR rate, this is very important, was 33%, and the overall response rate was close to 65%. And according to the histology, the overall response rate was 70% for angiomyoblastic, close to 60% for NOS, and roughly 50% for anaplastic. The median duration response, this is another important point, is 19 months, and the time to response is less than 2 months. And this is the data, preliminary phase 1 data, only less than 70 patients, but are really important in the issue of relapsed refractory patients with peripheral T-cell lymphoma. And also we have to remember two important points. The median progression of survival was 10 months, and the median overall survival was not reached. And the last, but not the least, the severity profile. No extrahematological toxicity, only hematological toxicity, grade 3 or more than 3 is neutropenia in at least 20% of the patient, 22% for thrombocytopenia. So these data are really impressive for this setting of real unmet medical need for our patient.
I agree. This is really a space where we are very underserved currently.
Finally, after the conventional treatment, in Europe, there are for second line Lymphocytic or there are Gemcitabine, where the overall response rate is less than 30%. The same situation in the United States with Pralatrexate and Belinostat, but no really good result. With this pathway, EZH2 inhibitor in this trial, but also the same data we can observe with valemetostat or in other pathway with Golidocidine, this is JAK1 inhibitor, we can increase the overall response more than 60% and also the CR rate 30%. I think this is the first step to move as soon as possible from the right to the left and also to try to combine. And this could be a really important point for our patients with this very bad disease.
And particularly also with the really very good toxicity profile. I mean, that makes it also for us so much easier to think about innovative ways of combining it with the situation.
Yeah.
The majority of drugs that we have seen in the past going through exploring T-cell lymphoma actually had horrendous toxicity. And now we have potentially something to work with for our patients. I mean, finally, we make a difference in T-cell lymphoma.
Yeah. We hope.
We hope. So I would also like to jump now to the next abstract as reporting about a new bispecific antibody CD3/CD19 in acute lymphoblastic lymphoma. And it was presented by Aldos from City of Hope. The compound is AZD0486, and it basically was in patients with 2 prior lines of therapy relapsing in full-blown relapse of acute lymphoblastic leukemia. I mean, this drug has been also explored in follicular lymphoma and also aggressive lymphoma, but this is now really working on the toughest B-cell lymphoma that we have, and that is BALL. And it's a classical phase 1/2 trial, and there was 3 parts, and it reported on the dose finding portion, and in a couple of dose steps up to DL5. That was the design. And at this meeting at EHA, 31 patients were reported in this clinical trial, heavily pretreated, the majority of them exposed to either blinatumomab or CAR T cells, or even double exposed. And the wording of the protocol was in regard of CD19 expression, have to have evidence of CD19. So I think very liberal in the situation. And as expected, there was cytokine release syndrome being sort of something to work with. So there were double steps included into the protocol. And to be said that at the DL3 group, it's 83% had a response in that situation, CR with MRD negativity. And particularly, and if you're looking at the numbers, in the patients which were blinatumomab exposed, 64% complete responses, and also the CAR exposed, 63%. So this is really a very active compound situation. And for the first time, we have now the sequence of a bispec on bispec targeting CD19. And that was the biggest loss that we were seeing, that the CD19, we lose it. But now this data shows you that you actually do maintain CD19. And I think the data is there that the CD19 exons that are targeted between the different antibody constructs are different to the blinatumomab and the CAR T cells. I think that is the thing. So what about the toxicity? We saw infection. This was to be expected in this patient group. Grade 3 is the majority of patients. Febrile neutropenia, increase of ALTs, and the heme. And the most important thing, ICANS, was only seen in 1 out of 31 patients. So the development of blinatumomab in that space showed 1 out of 8 patients. Now we have 1 out of 31 patients, grade 3 or grade 4 neurotoxicity. So this drug is moving forward now into the phase 2 part. And I think this is also something very exciting. I think this can be moving up the ladder very quickly in this hard-to-treat population of ALL.
Impressive. We opened the door of bispecifics in the setting of acute lymphoblastic leukemia. And I know that probably we already started with the same single agent in CLL.
Yes. And I think that is probably the better target in CLL than CD20, because there is dim expression in CLL.
Yes.
And CD19, you have a lot of expression of that. But
this could be another really important opportunities for our patients.
Absolutely. So I think I would like to wrap up. I think we have a lot of excitement for our field, more than ever, I believe. We have
absolutely.
We have really some 4 really confirmatory phase 3 trials with great data that's coming up there. We have 2 exciting compounds and something like that.
We are lucky to be in this kind of situation.
So
I think it's important for us, but it's absolutely important for our patients that we can increase the response, we can reduce the role of chemotherapy, and we have a different target for different kind of our patient situation. I mean, fantastic.
Yeah, we got a vision.
Yeah.
That's it. Thank you for being patient with us, and I hope you can share the excitement that we have for our patients and these new opportunities.
Thank you, Drs. Topp and Zinzani, for a great discussion and for sharing your expertise with us. And many thanks to you, our listeners, for joining us today. Be sure to check back for more episodes on important oncology topics.